Hello, I'm Dr. Peter Christ, and I'm here today to host the latest in the ACO's A Different Kind of Psychiatry case webinar series. And today we're going to hear about treating the elderly. It's never too late to start medical orgone therapy with Dr. Howard Chavis. Dr. Chavis is in practice in psychiatry, treating adults and children in Manhattan and Scarsdale, New York. He's board certified in psychiatry and medical orgone therapy. And last year, Dr. Chavis became the editor of the Journal of Orgonomy. So as you did back when we talked back in December at that webinar, Dr. Chavis, you've decided to present a number of different people instead of just one case that you've worked with, and this time about treating the elderly. So tell me and the audience something about why you decided to talk about this topic and these particular people.
Yes, first, hello, Dr. Christ, and hello, members of our audience. It's a pleasure to be here today. The question how I chose this particular topic, treating the elderly, the answer is quite simple. I happen to like old folks. I always have. Senior citizens, sometimes they're called seasoned citizens. But I remember as a young lad growing up in Brooklyn, New York, living in an apartment building, my walking across the hall, knocking on the door to say hello to Mrs. Terrell. She lived alone. She was probably in her early 80s. And I would join her in conversation. She'd be sitting in an antique rocking chair. She was obviously from New England. And I have no recollection of what we talked about, except that it was actually thoroughly enjoyable. I do remember she talked about her son who was in the Air Force. Also, I remember during my medical internship, one early morning, I admitted a patient. I took a history, did a physical exam, and then I sat there by the light of the lamp on the bedside table, just chatting, talking with this elderly patient, and thinking that I'm so lucky to be in this position as a physician, being able to have just chat, just talk with this older person. And a similar experience many times in my work as a psychiatrist with hospitalized medically ill patients, some of whom were older, as well as treating individual patients in my practice.
It strikes me, just now struck me how this is actually part of the whole story of what we have to tell as medical ergonomists is something you loved in your childhood has carried through as just a part of your basic healthy nature to give you satisfaction for years and years. I don't know, that it just hit me. So, yeah.
Yes, precisely.
Yeah.
Precisely. As for the particular patients I'll discuss today, and I saw these patients before the current COVID-19 pandemic, they and their treatment illustrate what is fundamental to medical orgone therapy. That is emotional contact, its depth and breadth, and the knowledge of human armor and how it affects the individual informs what I do, informs how I can help people lead a fuller life, even in the later stages of their life. So with that as an intro, I'll start with patient number one.
Good. Yeah, let's hear.
Okay. So Helen was a 71-year-old woman who was referred to me by her pulmonologist, who's treating her for advanced emphysema. She was sent to me because she had panic attacks, and he treated her with Elavil, a tricyclic antidepressant, which was a treatment back then. And she was on a whopping dose of this medication, which did not provide her with very much relief. So when I saw her as she came into my office, she was a sight to behold. She was tall. She walked in a robotic fashion, and her makeup was absolutely bizarre. It looked like she had applied it with a spatula. That's how thick it was. And she talked with in a robotic way, just like she walked. She trailed a small oxygen tank behind her with a nasal cannula to deliver the oxygen. Now, I was thinking, because I knew that she came to me for the treatment of panic attacks. As a medical ergonomist, I know that panic occurs when intense emotion held in the chest either tries to break through the muscular armor, the muscular rigidity in the chest, or that it actually breaks through. So I had an idea what I was going to do, how I was going to help her. But in terms of her bizarre appearance, I had no idea if this was the result of the high dose of Elavil she was taking daily, or whether this was her baseline, that this was her. So I explained to her what I wanted to do, that I was going to work physically with her. This was not going to be, a 10-year character analytic treatment. And she agreed to allow me to work physically with her. So on the couch, I had her turn over on her belly, and I worked a little bit on the back of her neck, which was tense. And I encouraged her to let out some sound, which she did. I then had her turn over, and I pressed on her chest. I actually, it almost looks a little bit like CPR. I'm going like this to her chest, between her breasts, and I press gently at first, and some sound came out. I wanted to introduce her to this kind of treatment, so I was not about to do very much more than that. Well, the session was over. She came back the following week, and sure enough, she actually did not have a panic attack during that week, which is extraordinary.
Yeah.
It's absolutely extraordinary. So with that, with that, I was able to work a bit more vigorously on the front of her chest and also on her neck, which was tense, and more sound came out. This time with a little bit more emotion. There was some fear, mostly, and maybe a tinge or a little touch of anger. With that, and the fact that she did not have a panic attack that previous week, I began to slowly taper her medication, taper the Elavil, very, very gradually. And so I saw her week after week. I was working more vigorously on the front of her, the anterior aspect or part of her chest, and more emotion came out, more intense fear came out. The fact is that she had advanced emphysema, and an emphysema patient has a hyperextended or hyperexpanded chest. That's the nature of the illness. So I knew I was not going to change that, but what I was addressing was whatever chronic muscular armor she had. And she didn't stop smoking. That's certainly, and the reason that I say that, and the reason I'm chuckling, is that even though her makeup went, she stopped looking bizarre. She was certainly a lot more appropriate in her in how she looked, but also that robotic quality to her speech and her walk totally disappeared.
So how do you understand that? What was it that was causing that bizarre appearance and the robotic thing that got overcome?
Yeah, I think it was the Elavil. I think she was on a huge dose of Elavil, and I think it was a side effect. And the physician who prescribed that, her pulmonologist, was doing what he knew how to do, which was to prescribe medication. And that was a standard treatment for panic attack back in the day. And so here, this bizarre character disappeared, but what emerged was her. And she was a character.
Okay. Yeah.
Again, I chuckle because here's this Brooklyn lady who loves to gamble.
Mm-hmm.
She loved to gamble. She played mahjong. She played canasta. She played maybe pinochle, whatever it was, with her girlfriends, and it was all for money. She always gambled. And up until the time that her advanced emphysema prevented her from traveling, she'd be traveling down to Atlantic City at least twice a week to gamble in the casinos. So here I am treating this woman, and she had a Brooklyn accent, like right out of the movies. And it was incredible that she emerged. And that's the nature of medical orgone therapy treatment, because what you see is more and more of the quote unquote real person. Once you alleviate armor, that begins to emerge.
Yeah. Well, as I often go back to, the three layers: the nature, the character, and the personality. So it's like you help get rid of the superficial facade, and then more of her character came out, and then underlying that, more of the things that give her pleasure and her nature. So
right. Yes.
The other thing that strikes me, just to underscore the definition that I have found so useful in orgonomy about anxiety, it's what we feel when an impulse does not have a satisfying outlet. So if that builds up and builds up, the person is going to get to the point where they go into a panic attack. And you allowed those impulses to come out, so it drained the energy out of the panic and out of the anxiety. I mean, it's just such a wonderful example of the work that you do and that we do as orgonomists.
Yes. Are you ready for patient number 2?
I'm ready. Yep. Are you ready?
I'm ready.
Good.
So Barbara is a 90-year-old widowed woman who lives alone. And she was referred to me for depression and anxiety. And over the course of my treatment of her, which was sitting up, my emotional contact with her allowed her to expand. And what that means is that at first she was, in talking about her past life and her present life, it came out in a complaining fashion. But gradually, this complaining quality turned to actual expression of, not actual expression, but expression of actual emotion. So that was what she talked about in terms of her daughter and her relationship with her daughter in years past. She was complaining just how frustrating it was. And she also talked about just how unsatisfying her marriage had been, and that her husband had not really contributed to raising their daughter. And that complaining quality turned to actual anger. And with that, her depression lifted. What she came to feel and see was that she actually was sad and lonely, that her social existence had shrunk. Friends had died, and that she lived alone. And so it was a painful existence. And then she was able to express this and to stand it, and she cried. That provided her with relief. At one point, in talking about the fact that she did not miss her husband, who had died years before, she told me, she said, "But I do miss the touch of a man. I do miss a man's touch."
Wow.
And then she said to me, "Can I hug you?" With that, I stood up. I stretched out my arms. She came into my arms, and I held her. I hugged her. Now, this was far more than just a hug. I was providing for her something she longed for her entire life. And that was acceptance. And this was huge.
Yes.
This was huge. And that basically encompasses how I helped her.
I mean, it's, again, such a great example of not following any particular rules, but just seeing what the patient truly needs on their healthy level, getting rid of the stuff in the way, and allowing them to come out with who they genuinely are. That's wonderful.
Yes.
Yeah. Yeah. Wonderful.
Yes. Thank you. The next patient is Rose. I met Rose when she was 86 years old in the intensive care unit in the hospital. And I was asked to see her because following a heart attack, she was depressed. And when I saw her in the hospital, she was afraid that her independent existence, because she was totally independent, was going to be compromised by her cardiac condition. Well, I provided perspective for her. And I said, we don't know. People have heart attacks and they go back to living exactly how they lived before. And that rather than jump to the conclusion that you're going to be incapacitated, let's see. Well, the long and the short of it is that she came to see me every single week.
Wow.
For the next 4 years.
Okay, great.
Here's this woman who maybe she was 5'2", maybe. She was certainly not frail, but she was, let's say, thin, on the thin side. And she came to me every single week, whether it was raining, whether it was snowing, whether there was ice on the ground, whether it was 95 degrees in the summer. And she was just absolutely incredible. And there again, the emotional contact and the depth of contact was profound. And she talked about her life. Here she's in her, her later 80s, and she's telling me about a blind date she went on when she was 16. She's told me, she said, the instant I saw him, I saw how short he was, and I knew he wasn't for me. She said, I'd have to shake out the sheets to find him. She also told me the following true story. She said she was talking with this guy, and they were talking, the conversation turned to sex. So she said to him, or she asked him, how often do you have sex? And this is characteristic of her. She was bold. So he said infrequently. And her response is that one word or two. Infrequently or infrequently.
So
he was naughty. She was naughty. It was absolutely a delight.
Yeah.
So great. She also had a tendency to be harsh with herself, to be hard on herself. And one day she comes in, and during a session, she tells me that she was taking a shower and she looked down at her body. And here she is in her late 80s. And she looked down at her body, and her response was, ugh. This is what she said. So I said, and what about your legs? And she laughed because she had gorgeous legs.
Great.
And that was great. Another time, she came in upset with herself. She told me, all I do is sit on the edge of my sofa, watch TV, and eat cake. Okay? So the session goes by, and at the very end of the session, uncharacteristically, she said to me, Dr. Chavis, what do you think I should do? This was like out of the blue. She had never. So this is what stumbled out of my mouth. I said, I think you should go home and have a piece of cake. And she laughed and laughed and laughed and laughed.
Yeah, talk about meeting people where they are.
And this is a reflection of emotional contact and the depth of emotional contact that's possible. And that's possible when armor does not interfere with the ability or the capacity to have an energetic connection, either with another person or a work of art, whatever it happens to be. And this is crucial to understand, that this is not a psychological process. It's not an intellectual process.
Right.
It's energetic. It's energy. This is not mystical.
Right.
This is real. And we know that with emotional contact, with that energetic contact, there's movement. And this is crucial in treatment, because what we do as medical ergonomists, we identify what interferes with movement. What are the obstacles? What's the armor? Whether it's muscular or whether it's attitudinal, that's what we identify and address. And that eliminates or alleviates the obstacle so that the person feels or is in contact with what they feel. That's true emotional contact.
Right.
And here I'm demonstrating through these cases, these patients, how emotional contact is absolutely such an essential part of treatment in medical orgone therapy.
Yeah. And in this case, you mentioned a specific aspect of her character, her being hard on herself.
Yes.
It sounds like that would get in the way of her expressing any emotions, her moving forward with whatever she wanted to do. So I just want to underscore is there's both the components, the muscular armor that you've talked about in some of the cases, but as you said, character attitudes, particular attitudes. So is there anything more to say about how that played out with her? Because I think a lot of people think, well, someone's character at the age of 80, you're not going to change it. But I don't have any doubt that you addressing that with her helped her make contact with herself in a better way. So
one correction, Dr. Chris. Yeah. She came to me at 86, and I treated her for 4 years until she was 90.
Okay.
So in my own way, I was addressing her character, but doing it in a seemingly light way.
Yes.
And this is also a crucial part of, for me, or the medical ergonomist, being in emotional contact, that things are said, where ideas come out and are expressed by me that seem to come out of nowhere.
Yeah.
But this is not magic.
Right. They don't come out.
Absolutely not magic. It comes out of the emotional contact with the patient. Yeah. So my stumbling out and saying, I think you should go home and eat a piece of cake, it's priceless.
Yes.
You know? And the fact that I was giving her permission was addressing her tendency to be hard on herself, to be harsh.
Well, great, wonderful. Yeah. I just wanted to underscore the importance of these things that, as you said, that seem like they come out of the blue. They're sort of a joke, they're light, but they're in the service of addressing a person's character, helping them overcome what's in the way, and coming out and expanding. So great, good.
Right. So there's another patient. Good. If we can move on.
Oh yeah.
And this patient's name was Hildy. And Hildy was an 80-year-old German retired bookkeeper who lived in her own apartment, but was admitted to the hospital after she fell and hit her head. She was confused and disoriented as a result. And a CT, a CAT scan, revealed what's called a subdural hematoma, which is a collection of blood under the dura, which is the lining covering the brain. She was treated with steroids, and her confusion and disorientation resolved very nicely. However, she was refusing to eat or drink. So they asked me, the psychiatrist, to come see her. So what I saw in this frail, seemingly hearing impaired, elderly, apathetic-looking, depressed-looking woman was what she said. She said, "I want to die." I asked her a few other questions, and she told me she felt a lump in her throat. Okay, so what I saw was limited mobility of her jaw, depressed respirations. She barely breathed, and she had a lost look in her eyes, or to her eyes. So I let her know what I wanted to do, and I did with her consent. I did the following: with a cotton-tipped applicator, I induced gagging. I also pushed her or moved her jaw forward, which elicited sobbing crying and her saying, "Mama, Mama," just like that.
Mm-hmm. Mm-hmm.
How long was that? Was that physical or biophysical treatment? 2 minutes?
Mm-hmm.
2 minutes.
Mm-hmm.
Following that treatment, she asked for a drink of water. And that evening, she had her first meal in weeks.
Wow.
So I saw her daily for these brief sessions.
Mm-hmm.
And that lost look, and it involved gagging.
Mm-hmm.
It involved having her move her face and breathe more deeply.
Mm-hmm.
And I pushed her mandible, the lower jaw forward, gently, but I did.
Mm-hmm.
This elicited misery and despair, and increasingly anger as well.
Mm-hmm.
So the lost look in her eye disappeared. And believe it or not, and this surprised the heck out of me, her hearing, which had seemed impaired, returned to normal.
Wow.
Yes, wow. Incredible.
Yeah.
So that she was able to voice some anger or frustration at the hospital routine, although she was interacting more and very nicely with the hospital staff. She was also eating, you know, but she said, I was overweight when I came in, so I'm not going to put on all this weight, you know. And, you know, she thanked me after each session. She obviously looked forward to seeing me because these were daily treatments. And how long was each treatment? You know, how long was my interaction? You know, maybe it was 3 or 4 or 5 minutes at the most. And I'm a friendly guy, so, you know, what can I say? But she was also able to tell me she did not like the physical work that I did with her. At some point, she was discharged to a rehab ward or unit in a nursing home. Hopefully only an interim step before she returned to independent living in her own apartment.
Wow.
Yeah.
A remarkable but a wonderful story. You know, and again, two of the key tools we have is addressing the character and addressing the muscular armor. And with her, clearly, I mean, those expressions we have, somebody being choked up, clearly she was literally choked up. Once she could let the misery out, she didn't have to choke off the rage as much, and some of that could come out. And you know, that then freed her up to both express herself, but also to have the impulse to eat again. So, yeah. I mean, it's in some ways it's so simple, and that's what makes it easy to get, as you said, mystical. You know, these are miracles, but if we really look at it, they are just simple, real phenomena about what people do with their energy and their emotions.
Yes.
The other thing that I want to mention that strikes me is the change in her hearing. The jaw and the bones in the inner ear embryologically come from the same place embryologically, and those embryological connections often have very real energetic connections. So I don't quite understand, but in some ways there's something very important in just those observations that can help us look. So sometimes I think hearing can get blocked just from the person just clamping down. I mean, it's, again, a great observation and something worth people following up and looking at other cases. So, yeah, great. Thank you. So I'm sure you have another case or two.
Well, do you want to hear about my oldest patient?
Yes, that would be great.
I'm chuckling because my oldest patient was 102 years old. And her son, who was only 75 or 76, asked her internist to send a psychiatrist to their home because he was concerned about her. The son was concerned about her. So sure enough, I make a house call, and here's this older woman, and I do a brief consultation, and she's okay. You know, there's no, I don't need to treat her. Let me rephrase.
Great.
Let me rephrase that. I can treat her, but this is not going to be a standard treatment. So what did I come up with? When I showed up at their apartment, I had the aide put music on their, their not loudspeaker, but to play music.
Yep.
What did I do with this 102-year-old woman, my patient? We danced.
Great.
and that was the treatment for her. But what I did after I danced with her for a while was I then sat down with her son, who was in need of treatment. And so I made house calls, once a week for a period of time, and I helped both of them.
What gave you the sense that putting the music on was the thing to do?
It just came to me. There's another patient I treated in the hospital who was terminally ill with cancer, and she was her energy level was so depleted that when I found out that she loved show tunes, she and I would sing show tunes. She couldn't get out of bed, but she could. She was too weak, but we sang show tunes. So clearly, the focus here is what will mobilize the patient. Yeah.
Well, and I would add to that, what is their natural impulse that's coming from their core, from their healthy part of their nature. And if you can sense that and tap into it, that's great. The only other thing I wanted to mention about that case is we don't have time for you to go into detail about it, I don't think, but just to underscore, there's the treatment of the individual, but then there's the treatment of the social setting. So you addressing her son is treating something in her social life that was essential. And so, and the ACO has training programs in medical or orgone therapy and a training program in social ergonomy, those two realms. Right in that one case, you were addressing both of them.
Yes.
Yeah. So I think this would be a good time to go to some questions and answers. But before we do, is there anything that you could say about how treating the elderly differs from treating younger patients?
Well,
or similarities.
Well, the fact is that treating the elderly brings up issues that you don't necessarily see with younger people. And that is the loneliness or the possible loneliness of old age. And what that refers to is how friends, people, friends who the person has known for 10, 20, 30, 40, 50, 60 years die. And that bereft feeling is so incredibly profound. It can certainly tie in with early life experience that are awakened with the death of someone close to them. It doesn't have to be a spouse. It could just be a friend. But that's one difference, the loneliness and the loss. But otherwise, it's very, very much the same. We look at breathing. I look at where the person is holding back, whether it's in an attitude or in muscular armor, and I address what I see and what's on the surface, what needs to be addressed to help the person to basically to move, to make contact with how they're holding back, that they're holding back, what they're holding back, and to release that so that they can express what's actually going on inside them.
Yeah, great. Which is a good segue, I think, to one of our questions was, you both have probably had elderly patients. Sometimes they can be set in their ways. At least that's the stereotype. Has that ever gotten in the way of their therapy more than with younger folks?
That's an excellent question. Now we're talking about me personally. And what I'm saying is, I have a sense of humor, in case you haven't figured that out up till now. But it's very helpful to have a sense of humor about people who are set in their ways. Mm-hmm. Because again, out of emotional contact, a deeper connection, energetic connection, it's possible to say things that they're absolutely spontaneous, that seem to come out of nowhere, seemingly left field, that absolutely apply. Again, I'm not looking to change a person, but to help them make contact with what's interfering with their own contact with themselves, what they're feeling, and how they're living. What I said in my introductory comments was to help people to have a fuller life, even in their later years. And that's what I do.
Yeah. Well, my experience is sometimes older people are much less rigid than younger people. And I think it's just very individual from person to person. But it reminds me of something that struck me at one point, that saying, you can't teach old dogs new tricks. Sometimes the only thing that's harder than that is teaching young dogs old tricks. That some people, the young people, can often get so set in their ways they don't want to try something new because it's too conservative or whatever, however you want to put it. So another question was said, did you help patient number 2 with further sessions to help her with her loneliness, and how?
Well, the answer to that is that just by being available to her, I was helping her. Again, we're talking about emotional contact and the depth of emotional contact. I mean, remember, if you think of your own experience, that most interactions with people are superficial. And often either frustrating or lacking significance. And here I am, available, emotionally available. I don't have to say it. The person feels it. Even if they're armored, they feel that there's something different. And it's real. This is not intellectual. It actually is energetic. And my being able to sustain that allows the person to expand energetically, emotionally, but energetically. And that's so real and so different that it's a takeaway for them. They can take it home. They can take that feeling home. And what I did in hugging her is so incredibly profound. It was so much more than a hug. She took a chance. Don't forget, she's from a different generation. And she said, "Can I hug you?"
Right.
That's extraordinary.
So that, which underscores how important it is to pay attention to whether you're initiating something or the patient is initiating it. Sometimes we as a therapist have to be the one that initiates something, but in this situation, that might have been a mistake, and you waited until she initiated it, and then you could respond. So I think it underscores how you can't approach this mechanically. That's not hugs are good, hugs are bad, or because that ties into one of the other questions was about that patient. When Dr. Chavis hugged the patient, were you worried about her transferring a romantic relationship onto you?
No, not at all. She wanted the touch of a man. I saw and felt nothing sexual. Let me put it this way. Nothing overtly sexual, meaning it wasn't a come on in any way. She just wanted to be held. She wanted to, the way she phrased it, she asked me if she could hug me. And that was, there was absolutely no, have I answered that accurately?
I think so.
Okay.
No, but again, it's why one of our requirements for our training is the therapist to have their own therapy, to be able to perceive clearly what's going on in us, to know, is that coming from me? Is it coming from them? Is this a neurotic reaction from the patient, or is it coming from their core? Because if we can't differentiate what we call primary healthy impulses from secondary neurotic ones, we're not going to be able to help the patient do that. So I think that case illustrates that very nicely.
Yeah. Yes.
One other question is, if the topic of death comes up working with an elderly patient, how do you handle
It very much depends on the context and also who is bringing this up. Because I can provide a few examples. One example is from a patient who I presented in this December, when she said, well, in the course of her session, something like, maybe I have 5 or 10 years left. And she was clearly alluding to the fact that of a limited lifespan. So my response to her was, come on. I said, you have to live to be at least 100. And I said, and I knew this because I know she hates Trump. I said, you have to live to be at least 100 to get a congratulatory letter from the White House, not signed by Trump. and she laughed like crazy. But the other point though is that there are times when death or the thought of death or feelings about death comes up, and I'm able to be with the patient, just to stay with what they feel and not interfere. Because if my own, let's say, a defensive reaction, not being able to tolerate the intensity of what they feel, was to be funny or humorous or to treat it lightly, I would be interfering with their treatment. Fortunately, I don't. I'm able to just be present, to maintain that emotional connection, and to treat it as it should be treated. Again, depending upon what the context is.
Yeah. There was another question, sort of related to that. If therapy is about letting go, what about people's sense of letting go in terms of death? So I think you may have already answered that, but it's interesting that two people raised the question about with death.
And again, the context is letting go. So the subject death can be talked about in regard to letting go and what their thoughts are, what the feeling is. How does that register with them? When they're talking about this, what do they notice? What do they sense in themselves when they bring up the subject? I may not even directly refer to death, but talk about the process. Yeah.
You're also saying, reminding me just sort of a sense that I often have working with elderly patients or older patients that in some ways their life experience allows me to be much more open with them in a certain way. It's like you're not going to throw them off. They've seen it, they've been through all sorts of things, and in some ways that makes it easier. I don't have to worry as much about, God, is this young kid going to misinterpret what I'm saying? I mean, often they're, at least people who allow themselves to develop wisdom with old age, it allows it to be much easier to work with them, in my experience.
Yes. Yeah. That reminds me of my dear Uncle Leo, who died, I think maybe 10 years or so ago, or more, actually more. And as an adult, I asked him, I said, how did you get to be so wise? And his response was, I've lived longer than you, and I've made more mistakes. It was extraordinary.
Yes, that is extraordinary.
It was absolutely extraordinary.
Yeah. So one other question is can you go too fast in therapy, and what are the indicators for progressing too fast? And do you always have to clear tension in the eyes and forehead first?
Are we talking about treating the elderly or treating in general?
It sounds like treating in general.
Yeah. Well, I have a current patient who wants to move faster.
Uh-huh.
He absolutely wants to move faster. What does this reflect? What does this reflect? His tendency to push.
Right.
And pushing takes him out of touch with himself.
Mm-hmm.
And that's his primary difficulty.
Mm-hmm.
Being able to just stay with what's happening in the moment.
Mm-hmm. Yeah, no, that's my experience with many patients. They either get ahead of themselves or they hold back and are behind themselves. But just staying, having people stay right where they are, what they're feeling, is really what's crucial. Yeah.
And it's challenging for them.
Yes. Yeah. Well, there was another question that I think you've addressed or alluded to, I think, with the first patient, but maybe to go into it a little bit more. If the patient has a medical illness, how does it affect the treatment?
Yeah, that's an excellent question. And because I'm a physician, I'm actually a physician first. Mm-hmm. I've had not only medical training in medical school and a medical internship, but me personally, I've moonlighted in a medical ER for 3 or 4 years, actually 4 years. Mm. So not only was I a good student in medical school, but I also had very practical experience working with the medically ill. Interestingly, I used to also make house calls as a psychiatrist. Mm. And in a large percentage of these patients, because I was asked to see them for so-called psychiatric symptoms, on the spot, I made a medical diagnosis because their psychiatric symptoms were determined by a medical illness. But in terms of just treating patients in my office, it's crucial that I know what's going on medically so that I can tailor the treatment to their medical condition. For example, somebody who has high blood pressure or asthma, but let's take high blood pressure. There's a lot of feeling that's stuck in the chest. And I can help alleviate the high blood pressure by working on the neck, the jaw, and the chest. And it's remarkable, if caught early enough, before there's actual changes in the tissues and in the anatomy, I can alleviate illness. That's not true for every case, but in many cases I can.
Yeah. No, that my sense is that we are have a great approach for treating emotional illnesses, and amazing understanding of physical illnesses, but not yet quite the same technical knowledge about how to treat them. But you can't separate the emotions from the body. I mean, that's one of the essences of medical orgone therapy.
Yes, and to consider the effect of armor.
Right.
And that armor, chronic armor, can produce physical illness.
Yeah.
Symptoms of physical illness.
Yeah. No, you just reminded me of one of my cases, probably one of my older cases also, but a woman whose husband died. She remarried and dropped out of therapy for a bit, but then she came back with terrible skin rashes, eczema, a moon face from being on steroids for treatment of that. And I knew her well enough from earlier to know that she had a tendency to literally have conversion physiological symptoms. And I thought this was probably an hysterical symptom, even though it clearly was physical. And once we identified that her new husband was getting under her skin, literally in about a week, the skin problem cleared up.
Yeah.
So, that connection between, and none of the doctors were trained in the old-fashioned understanding of hysteria and treated mechanically with medications. So, yeah. So, anything else you want to add that you'd like to leave the audience with about working with the elderly? I mean, this has been a wonderful presentation, and to hear your connection with these patients, your genuine love for them and caring for them. It's just great to see, Dr. Chavis.
Yeah, I can reiterate what I said in the very beginning, that these patients and their treatment illustrate what is fundamental to medical orgone therapy, that emotional contact and its depth and a knowledge of human armor and how it affects the individual informs my treatment of these elderly patients, that allows them to lead a fuller life, even in the later stages or the later years of their lives.
Yeah, I think that's so important, is, increasing someone's satisfaction. It doesn't matter what point of life they're in.
Yes.
You have done a tremendous service to them if you've done that.
Yes.
Yeah. All right. Well, thank you very much, Dr. Chavis. It's been a wonderful presentation, and I'm glad that we've had a chance to talk again together. So,
thank you, Dr. Chris.
Thank you. And I also want to thank our staff for making these webinars possible. And I want to thank all of you in the audience for joining us today. And be aware that many of our webinars are turned into the podcasts that we have, and many of them are also posted as the videos that can be watched. If you know anybody who would like to go back and view this one, the ones we decide to post are posted both on the ACO website as well as on the ACO YouTube channel. So you can go back and see some of the previous ones in both of those places. And I also want to thank all of our donors who have generously supported the American College of Orgonomy and made it possible for us to do these webinars and to bring them to you. And I want to announce what's coming up. We're taking a break in April, but we'll be back in May, on May 14th, 2022 at 4 o'clock with Dr. Bosworth, hosted by Dr. Burritt, discussing handling a teenager's rage in therapy. So watch for our email announcements, and also follow the ACO website for any information about the next ones and future webinars in the case presentation series. So at this point, we'll sign off, and hope to see you at a future webinar. Thank you.